You can see his leadership quality. He is currently the president of the Malaysian Thoracic Society (MTS) and the Sleep Disorder Society of Malaysia. And he is currently the Congress president of the Asian Pacific Society of Respirology. Don't ask me how he has the time. He also is the vice president of the College of Physicians Malaysia. And with that, I would pass the space to Prof. Izwan. Over to you,
Thank you very much to Prof. Rohana for the kind introduction. Let me just share my slide. And of course, thank you to Mayos for this kind invitation for me to join the webinar, and as well as Zurich Pharma for sponsoring this event. Can I just check that you can see my slide clearly and you can hear me clearly?
Yes, Prof.
All right, okay. So I think it's not so long ago where the measures of how well you sleep depends on how loud your snoring is, which is really a myth. So we do know that obstructive sleep apnea is quite common. When we talk about obesity and sleep apnea, these two have a very well established epidemiologic, pathophysiologic, and clinical association. As mentioned by Prof. Rohana just now, obesity predisposes to upper airway obstruction via adipose tissue deposition, and then it will lead to altered respiratory mechanics as well as impact ventilatory control. And this will contribute to the development of obstructive sleep apnea, which is the most common sleep apnea phenotype in this population, in the obesity population. Given the high and under-recognized prevalence of sleep apnea in persons with obesity and the downstream impacts on cardiovascular risk, quality of life, and perioperative outcomes, so we do recommend targeted screening in at-risk obese individual, which is really essential for proper management and of this condition. So these are my speaker disclosure. What I'm going to share over the next 20 minutes also is to go through the information sharing on what is OSA, how we should recognize this, and what would be the complication associated with it, and talk about a landmark study in terms of what treatment can be considered for this particular patient. So let's start off by talking about OSA. What is OSA? So if we imagine OSA is what happened during OSA is where your upper airways become blocked, or you have a floppy part of your upper airways become obstructed, and that would lead to repetitive breathing cessation due to upper airway collapse. And a simpler way to explain this is when you ask the patient to do this simple test. When you check oxygen saturation for a patient when they're awake, you're probably going to get between 98 to 99% if they don't smoke. You can ask them to hold their breath for a while, and it's going to be very difficult for them to even drop 1 to 2%. But what happens when this patient asleep, when they have underlying obstructive sleep apnea, because of that repetitive breathing cessation due to their upper airway collapse, they don't get enough oxygen. So your oxygen level going to drop and continue to drop. And that's where you stop breathing. Then what will happen is they will kick off a response to your heart. That's why you lost your dip in your blood pressure when you're asleep. Your heart rate is going to be higher, and even though people see you asleep, you are actually running a marathon when you're asleep. And that would lead to a couple of symptoms that would include unrefreshing sleep, daytime sleepiness because they feel tired. They don't actually get a proper rest when they're asleep. They could have fatigue or insomnia, or they even have a recurrent awakening with feeling gasping or choking sensation. So when your oxygen drop, the way we are designed, human design, we don't continue to let the oxygenation to continue to drop. So it will get to one stage where it will trigger a mechanism to wake you up so that you can breathe again. Otherwise, you're going to go dead. So with this problem, you are able to breathe again, but you don't have a solid sleep, or when you have a really a fragmentation of sleep because of this problem. And we do need to be aware that this condition can affect both children and adults. But for this particular talk, I will just focus on what happens to adult patients. So things that you should know when you have sleep apnea, your breathing could reduce or even stop. You could have a loud snoring, but sometimes the snoring does not really affect the patient themselves. It would affect the bed partner. So I always mention snoring is not something that would bother you, but what happened to your heart, to your brain, to your metabolic problems is what you should concern about. Uh, and the most worryingly is the fact that most of us would have no ideas that this happened when we're asleep. So we just thought we just normally sleep, and then suddenly in the morning we feel so tired, we feel so sleepy, and so on, and we don't have any explanation of this happen, and that would lead to a really poor detection of this condition. It is successfully can be successfully treated, so we do have a good um, methods or to treat this condition. So we do need to increase the awareness of this condition so that we can give a proper treatment. I think Prof. Rohana mentioned about the vicious cycle that happened. So this is to explain further in terms of the pathophysiology. So when we talk about sleep disorder, breathing is a spectrum of disorder characterized by abnormal respiratory patterns during sleep. It will start off with loud snoring all the way up to obstructive sleep apnea, or even more concerning would be hypoxemic respiratory failure. And OSA is the most prevalent form of sleep disorder breathing, resulting from the recurrent upper airway collapse, leading to intermittent hypoxia, sleep fragmentation, and sympathetic activation. Some of the key risk factors for the development of OSA would include obesity, age, and male gender. And this is the map to show the prevalence of it. If you focus to the figure on your left side there, when we map this out to our Malaysian population, we estimate at least a third of our adult population are at risk of moderate to severe OSA, and we do need to be aware of this. So it is a disease of high prevalence but low recognition. So it's very important for us to recognize as there are effective treatment for this condition. And with the effective treatment, we can, in the end, reduce the cardiometabolic plus perioperative risk associated with it. Those maps show the figure in the general population, but if you zoom in into certain medical condition, the figure will be higher. So in type 2 diabetes, for example, there are estimated between 65 to 85% suffer from OSA, 73 to 82% in those who are having resistant hypertension. And in fact, when you look at the previous CPG, they did mention OSA as one of the main thing that you have to think about when you think about secondary hypertension. Stroke, it can go up to about 71%. Atrial fibrillation also had a very high prevalence, up to 85%. And of course, with obesity, it can go all the way up to 90% of obese patients. And the main three things that happen from pathophysiology point of view would be the intermittent hypoxia, sleep fragmentation, and there will be a large intrathoracic pressure swing. And that would lead to all these complications. So when you lost the dip in your blood pressure, when you lost your sympathetic activation control of your heart rate, that will put higher pressure to your heart, and that's how you get hypertension, myocardial infarction, or even the risk of developing atrial fibrillation and stroke. And of course, with metabolic condition, because of the effect on the insulin resistance, that will lead to development of type 2 diabetes and obesity. So let's zoom in terms of the relationship between weight loss and obesity. So when we talk about OSA and obesity, obesity is the strongest modifiable risk factor for OSA, with more than 70% of individuals with OSA classified as overweight or obese. The interplay between increasing BMI, central adiposity, and STB underlies a bidirectional relationship. I mean, obesity would promote sleep apnea, and sleep apnea would worsen the metabolic dysregulation. This is what we call the vicious circle. So you obese, you had a low energy, you tend to eat more. When you eat more, you increase your adipose tissue, especially around the neck. You make your sleep apnea even worse with that problem. And when we look at the pathophysiology point of view, this is a complex connection between sleep apnea and obesity. And you can see that there's an interaction between both biological as well as lifestyle factors as well in terms of how these two conditions interact. So this is what we call the obesity vicious cycle. So OSA and obesity are often seen together. So patient would get caught easily in the cycle with no clear beginning and no clear way. So we do need to treat these two together so that it will break this vicious cycle. And we do know that by treating obesity, for example, we can see from this particular study showing that when you reduce your body weight, you can see the reduction in AHI, which is the measure of severity of the obstructive sleep apnea. So a 10% weight gain would predict roughly about 32% increase in AHI and six-fold increase in the odds of developing moderate to severe sleep disordered breathing. So how do we identify and manage a patient with OSA? We've come up with this guideline in the past few years, and we've come up with this algorithm in terms of how this condition should be detected. So we recommend the use of a screening questionnaire to identify who will be at higher risk of developing this condition. But in terms of a certain condition, the recommendation will be slightly more than just a simple screening like that. So I'll go through in details in terms of that. So when we talk about OSA is suspected in the presence of clinical signs and symptoms, as well as positive screening questionnaire. And the way we diagnose will be a confirmation through a sleep study. There are 4 levels of sleep study in terms of the diagnosing. We need to use either level 1, level 2, or level 3. Level 4 sleep study, which is usually mainly just to measure your oxygen saturation throughout the night. That's mainly for your screening purposes. So we do need to look at patient with this symptom. So obese patient who had loud snoring, witnessed apnea, daytime sleepiness, morning headaches, or even those who had comorbidities such as resistant hypertension, type 2 diabetes, atrial fibrillation, and heart failure should be screened for this condition. However, those who had severe obesity, those who had a BMI of more than 35, or even those who are planned to have a bariatric surgery, we would recommend a routine screening for this condition because there's a very high incidence of OSA among this particular population. So the prevalence and severity of sleep apnea would increase with rising BMI. So individuals with BMI of more than 30, especially more than 35, they would have very high pre-test probability of moderate to severe OSA. So in terms of patient undergoing bariatric and severe obesity, we would recommend a routine screening for this particular patient. And what can we use as a screening tool? There are a couple of questionnaires. These are the ones that we analyze in our CPG. You can either use a stop bank questionnaire, which is very simple, yes and no questionnaire, Berlin questionnaire, as well as Epworth sleepiness, which mainly to detect the presence of excessive daytime sleepiness. So these are the example of the questionnaire. All these three questionnaire had the Malay version been validated in Malaysia already. So you can have access to this. You can refer to our CPG for the detail of where to get the Malay version of that. Apart from that, we also recommend doing a simple examination, especially looking at the mouth to identify airway crowding by using Malampati grading. So following the screening test, patient would be considered high risk if they scored a stop bank questionnaire of more than 3, or if they are in the high risk category of the Berlin questionnaire, or even if they have objective downward trends in overnight oximetry. And this particular patient would warrant further diagnostic testing with sleep assessment, and this patient should be followed up with polysomnography as a gold standard, or even to consider home sleep apnea testing, which is really getting more favor nowadays in Malaysia because of the access to sleep lab in Malaysia. So a pragmatic way for screening will be to identify obesity, should apply stop bank. If they are on high risk, we should consider sleep study. If they are low risk, we can simply just monitor. In terms of the management of OSA, you can divide into non-invasive and invasive method. So non-invasive method would include the use of CPAP, which is a positive airway pressure, lifestyle changes in terms of advising on their exercise, weight reduction, or you can even also consider oral appliance, which is normally done by our dentist or our maxillofacial surgeon. In terms of the invasive surgical option, you can either consider upper airway surgical procedures, bariatric surgery for extreme obesity, as well as these new techniques called hypoglossal nerve stimulation. However, the last couple of years, we've seen quite a number of pharmacological therapy, especially targeting a weight reduction, talking about liraglutide, semaglutide, and tirzepatide, is getting more favor as an adjunct therapy to treat OSA, especially in those with obesity. So let me focus on tirzepatide. So this is the paper who was led by Prof. Atul Malhotra. There was a picture of me, I think more than 10 years ago now, when he visited Malaysia for APSR Congress in 2015. And when we talk about tirzepatide, it's basically two in one study. So they want to look at how useful tirzepatide in patient either already on treatment for OSA with CPAP, or those who are haven't started on any forms of treatment, and they would be randomized to receive this on the increment dosage and to see the effect following 52 weeks of treatment. So what is tirzepatide? Tirzepatide, as we all know, is a dual GIP receptor and GLP-1 receptor antagonist. It's an amino acid linear peptide and includes a C20 fatty acid. It is a multifunctional peptide and had a half-life of about 5 days with no clinically relevant effects on renal impairment. So it's a good medication to be considered commonly used in type 2 diabetes as well as chronic weight management in Malaysia. So in that particular study, we can look at the baseline patient characteristic, and we can see that the patient BMI, as well as in terms of the severity of their OSA, most of them are in moderate to severe category. So whether they are on CPAP, which is the study 2, or if they are treatment naive or CPAP naive patient, which is in study 1. And when we look at their primary endpoint, you can see a significant reduction in AHI, or the measurement of severity of OSA. So those who were treatment naive to CPAP had a reduction of nearly 20 unit of AHI. And those who were already on CPAP therapy, they have a reduction of about 23 unit of AHI. And in terms of participant with clinically meaningful changes in AHI, by definition, is a more than 50% reduction in baseline AHI at the end of the studies. So you can look at study 1, which is naive patient, had a significant reduction of nearly about all the way up from 61% to 19%, with a relative risk reduction of about 3.3, and similar result for those who were already on CPAP therapy. This one is looking at those who would achieve remission or mild non-symptomatic OSA, meaning that with this treatment, it can even lead to a resolution of OSA. And this happened with also changes in body weight. So you can see a significant weight reduction in both groups. And in terms of adverse event, it's very comparable. So most of the adverse event would be the gastrointestinal effect, and most of them were quite mild in those two studies. So what you can conclude from this particular SURMOUNT OSA study: adults with moderate to severe OSA and obesity showed to have a significant and clinically relevant decrease in AHI when you add in tirzepatide to the treatment regime compared to placebo. So whether they're already on CPAP therapy or even treatment naive, addition of tirzepatide show a good reduction in AHI, and you can do this safely and pretty much very tolerated medication, with the most frequent adverse event were GI related side effect, which is mild to moderate symptoms. So following that study, European guideline in terms of obesity treatment framework already recommend the use of tirzepatide, especially when you have OSA. So for those patients with OSA, because of the SURMOUNT study, we recommend the use of tirzepatide as a treatment option for this. So this is my last slide. We need to recognize that obesity is the most significant risk factor for OSA development. So we do need to target weight reduction. So with significant weight reduction, it will address the underlying cause of OSA. And in some, you would even expect cure of OSA in those patients. And supported by weight loss study, we can see that weight reduction has become a pillar in OSA management. And this particular study particularly highlighted the benefits of tirzepatide in reducing the AHI, which is the measure of OSA severity, as well as improving quality of life in patients with both OSA and obesity. And with that, I thank you. Before I end, there are two important meetings coming up, which I would like to invite all of you to join. Thank you very much.
Thank you very much, Prof. Izwan. I must say it's a bit weird watching someone else present on GLP-1 when we're always the one doing it. And you have done it so aptly. But as well as that, I also want to say that the picture that you shared is one which was from 10 years ago, did you say? Right?
Yes.
Oh, but you look exactly the same. So that's me complimenting you.
Alhamdulillah. Good to know.
Right. Okay. So we've got questions coming, but we're going to entertain your questions, ladies and gentlemen, at the very end. So now it gives me great pleasure to introduce our second speaker. So Dr. Hariyati Shahrima Abdul Majid, if I can just have her bio up. Yes, thank you. She is currently in the board of studies member of the. Sorry, I'm going to say that she is currently one of the sorry, I've lost it. She is currently in IJN College November 2023, and I'm very impressed with this because I didn't even know. She has been an academician in IIUM prior to that, holding academic administrative posts. She has a PhD in psychology and master's in applied psychology from the University of Surrey, UK, and her BSc in psychology from University of Wisconsin Madison, USA in 1992. That will explain her slang you will soon to hear. She also had a master's in clinical psychology program UITM, master's in disaster risk management at UTM, as well as external industrial advisor for the psychology program at UCMI. She is currently a member of the American Psychological Association, Persatuan Psychology Malaysia, Malaysian Diabetes Education Society, MDES, and also Hospice Negeri Sembilan. She is a certified trainer and she trains healthcare providers on motivational interviewing and behavioral change, stress management, therapeutic communication, and psychological first aid. So, Dr. Hariyati, we're very excited to hear from you. Please take it away.
Thank you very much, Prof. Rohana. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Very good afternoon. Thank you for that kind introduction, Prof. It is an honor to be in the same panel as you, as well as Prof. Izwan. And thank you to Malaysian Obesity Society. I think this is the first time that I am involved in your program, and I hope that I will be able to share and meet expectations from the Malaysian Obesity Society with this presentation. And thank you also to Zulik Pharma, especially Kayan, for your professionalism and your patience with me. All right, so today I've been given the responsibility to talk about mind, mood, and metabolism, the psychological and sleep dimensions of obesity. And it's actually a very tough topic to prepare. So I've taken the liberty to focus specifically on mood, mind, and sleep specifically to highlight to you a variable that's often overlooked, and that is psychosocial as well as mental health. And I'm glad that Prof. Rohana has actually highlighted the interest in psychological, psychosocial factors, as well as mental health factors in affecting sleep, in affecting obesity, in affecting health outcomes. All right, so this is a speaker disclosure. Like I said, this is the first time that I'm working with this group, and I hope that I will gain your trust to contribute further in the future. So the outline of my presentation today, so what I've decided to do is to actually bring a little bit more patient-centric approach to this topic and talk about things from how what patients go through on a daily basis. So I'm going to share with you a day in the life of a patient living with obesity. And I'm going to talk about the relationship between sleep, mood, and obesity, and focusing or having the biopsychosocial model as the framework. And I'm going to share with you some research evidence on sleep and obesity, mood and obesity, and sleep, mood, and obesity. And hopefully share with you by the end some strategies to support patients, to have a look at our resources to support patients, and a take-home message. So this is a day in the life of Hariyati, not her real name. She was diagnosed with type 2 diabetes 2 years ago. A year ago, she was prescribed medication. She has BMI of 32. It has not changed since the last time she visited the hospital. And her attending doctor finds it too difficult to manage her. She's referred to you for non-adherence to medication and her failure to change her health-related lifestyle. Puan Yati is a single mother with 3 school-going children, and she works as a guru kanan, HEM, during the day and attends a diploma program at night. This is what she says to you. She's developed some trust in you and she shares this with you at the current session. She says, Doktor, saya tahu saya perlu sihat, Doktor. Bukan saya tak nak. Saya dah cuba makan ubat seperti yang doktor sarankan. Dan bukan saya tak cuba tukar cara pemakanan saya. Tapi doktor, saya penat. Setiap hari kena fikirkan pasal kelangsungan hidup saya. Nak jaga anak, nak cari duit. Lepas tu nak makan ubat, kena jaga makan. Kira kalori lah. Nak tengok gula dalam darah lah. Dan lama saya tak cukup tidur. Bangun pagi, saya penat. Penat fikir doktor juga. Bukan saya tak nak buat semua tu, tapi tak mampu. Lepas tu doktor minta tolongkan saya berat badan. Macamlah saya ada masa nak exercise. Alright, so this could be part of it, or the whole complete conversation is something that you hear in your clinic. So the question here is, which do you treat first? Alright, do you treat the obesity first? Do you treat the mood first? Do you treat the sleep first? And as you will realize later, or as we will agree or have agreed now, it is not an easy question to answer. All right. But I think it's very important that we realize the importance of looking at the person, the patient living with all these factors that could contribute to her sleep quality as well as her mood, and which contributes to her inability to lose the weight as recommended by the healthcare providers. So as you know, obesity is rising and it's strongly associated with sleep problems, and it is strongly associated with depression and anxiety, as Prof. Rohana had highlighted earlier, and poor outcomes when treated in isolation. And I think that's very, very important. Obesity is rising and it is strongly associated with poor outcomes when treated in isolation. And obesity is driven by different factors. It is driven by mood, it's driven by sleep, hormones, restoration, and as well as behaviors. And these are interconnected, they're not separate issues. And one of the models I am sure that you are familiar with is the biopsychosocial model of health and illness. When we talk about behaviors that lead to becoming overweight and obese, we have to explain it. We have to try to see it from the biological perspective. We have to look at the psychological perspective, and we have to look at the social and environmental perspective. So the biological perspective includes appetite control, genetics, and the stress response system. Corticols, for instance, is the hormone associated with obesity. And it's also associated very much with stress, chronic stress specifically. And the psychological variables that are associated with being overweight and obese is food cues and preferences, adverse psychological experiences. People tend to actually turn to food for emotional, emotional health. But it has also to do with a lot with how you think about food, how you think about obesity. It's also a lot to do with how you think about sleep. And these attitudes, these perceptions, these beliefs can become core to the changes or to the lifestyle changes that we adopt. Of course, the social and environmental factors, you cannot talk about Malaysia without talking about food, ease of walking around neighborhood especially, and the stigma attached to obesity. So as you look at this model, it is a simple model, but the variables that are found or that explain this model can be varied, can be diverse. So sleep and obesity. First and foremost, I'm going to introduce to you, I'm going to share with you the background. Poor sleep is recognized as a risk factor for developing obesity, while existing obesity frequently causes sleep disorders, creating a vicious cycle. And I think Prof. Izuan has used the word earlier, a vicious cycle of metabolic, mental, and physical dysfunctioning. And research evidence shows that obesity, all right, and potentially by contributing to obesity, abnormal sleep duration increases the risk of chronic cardiovascular health conditions and increased mortality risk. And the American Heart Association added sleep health to the list of the key factors that are essential to improving and maintaining cardiovascular health as part of their life's essential aid. And I find that usually in sessions, I don't hear sleep being assessed. For instance, recently I was at the pharmacy, and this patient who was on the overweight side, who was purchasing her medication for diabetes, she was asking the pharmacist. She said, "Puan, saya ada masalah tidur. Saya tak boleh tidur. Dah berapa minggu dah saya tak boleh tidur." Um, but it was actually not addressed. I was there and I was listening to this conversation, and I wanted to actually interfere, but I was not in the position to do so. But all the pharmacist did was to actually say, "Puan jangan overthink, puan tidur je, puan relax, puan tidur. And puan makan ubat, puan jangan fikir apa-apa." But she kept saying, "Saya ada masalah tidur, saya tak boleh tidur. Saya worried. Masa saya tak boleh tidur." So I find that to be a real concern, a genuine concern voiced by the patient, but we may not have the ability to communicate or respond back to this patient in helping her to think about sleep in a different way. All right. And sleep obesity, the association of short sleep with obesity is seen in adults and children back in by this meta-analysis that was published in 2008. And in a very old study, I think it was 20 years ago, in the nurses' health study, what they found was that there's a relationship between weight gain by hours of sleep, where people with less than 6 hours of sleep per night, nurses, had a weight gain of more than 2.5 pounds. And results also show in this particular study that good sleep regularity was associated with higher odds of weight loss and maintenance, and good sleep quality was associated with higher odds of weight maintenance. So it is not just about the number of hours of sleep that you get, it's about being able to get regular sleep. So when I see my patients, one of the first questions I ask, whatever condition that they come to me with or they refer to me for, one of the first questions I ask is, how has your sleep been? How do you find your sleep this past 2 weeks? Have you been able to sleep at the time that you want to sleep? Have you been able to stay asleep? And do you feel refreshed after waking up? Although you're after having a good night's sleep, after having a 7 or 8 hours sleep. And just from the responses that patients give, you have an indication of what their quality of life has been like. So how does sleep contribute to obesity and other health complications? And as we know, short sleep duration could contribute to increased hunger and less satiety. This has to do with the hunger hormone of ghrelin and the satiety hormone of leptin. And as a result also, and it's also related to more cravings for high sugar. So body is biologically pushed towards overeating. So when you do not have enough sleep, the time itself, you wake up, what do? You turn to food. You open up your refrigerator, or you turn to food for comfort, or you turn to food for companionship. All right. So the sleep and obesity cycle, you have sleep deprivation, there is going to be hormonal imbalance, there is going to be high likely increased hunger and cravings, and high calorie intake, weight gain and obesity, and poor sleep quality. When I provide training, or when I teach in classes, I always say, when you're stressed out, when you're not able to sleep well, do you go for an avocado? Do you go for a salad? You don't go for salad. You look for ice cream. You look for cakes, leftover cakes. You look for things that are high in sugar. So obesity, and I think all of us agree here, is a complex chronic disease with a bidirectional relationship with sleep quality and sleep duration. So sleep, we're not just talking about being able to have sleep, enough sleep, or the length of sleep. We talk about duration of sleep and quality of sleep as well. What about mood and obesity? Of course, there is a well-established association between mood and, in this case, stress. I'm not going to talk about post-traumatic disorder. I'm not going to talk about major depressive disorder. Stress, something that all of us go through in one way or another, different levels on one another in obesity in adulthood. So obesity impacts mental health, increasing the risk of depression by up to 55%, while depression increases the risk of obesity by similar percentage, about 58%. Although you can see here that depression increases the risk of obesity a little bit higher, 37 to 58% compared to the other way around. And this relationship is driven by biological factors, psychological factors, as well as social factors. The same thing as sleep just now. How? The experience of chronic stress increases the risk of excessive weight gain, both directly and indirectly, both physiologically through the activation of the stress response system, or through the release of cortisols, as well as the activities in the prefrontal cortex. So reduced activity in the prefrontal cortex, for instance, make it more likely for people to eat when they're not hungry and have a decreased ability to regulate their diet and eating behavior. And prefrontal cortex is associated with decision making, problem solving. So when you don't have enough sleep and your stress is very high, prefrontal cortex, part of the brain that regulates all these higher order cognitive processes, may be affected. And hormones responsible for regulating appetite compromise our ability to respond to signals associated with being full. So there are different studies that have been conducted on stress and eating behavior among Malaysian adolescents prior to examination, as well as young adults in the aftermath of the COVID pandemic, showing that there is a relationship between eating patterns as well as mental health status. So what about the relationship between sleep, mood, and obesity? Results show in this particular study that 74.8% of participants were poor sleepers, and their mean self-reported sleep duration was only 6 hours and 20 minutes. And after controlling for all the other variables, they found that poor sleep quality is associated with mood disturbance and lower quality of life among people with extreme obesity. And in addition, it shows that obesity showed a modest partial mediating role between sleep duration and depressive symptoms in this particular study. So we agree that high occurrence of sleep problems and mood disorders and obesity, and it is reinforcing. It's difficult to actually identify which is the chicken, which is the egg, and in this case, the first egg or the second egg. So we need to break the vicious cycle. It is a vicious cycle. So very quickly, I'm going to end by talking about Puan Yati. So remember, Puan Yati has her own story to tell. All right. For her, most likely, obesity is not the most important issue in her life. Her stories, she needs to have space to be able to talk about her worries and concerns about her health, about the challenges that she faced, about the past and current efforts. And I think this is something that we often overlook. We don't look at the efforts being made by patients in trying to help themselves in terms of taking care of their health. We often overlook or undermine because we don't see the results. For instance, I did gain weight while I was taking care of my dad, who's now passed. So after his passing, I reclaimed my peace by going back to healthy lifestyles, and I lost about 3 kilograms, but in 5 months. And I said this to the doctor, and the doctor says, "Tak cukup lagi ni, you're gonna lose more weight." But I was thinking it's not easy for someone like me, with back problems, with thyroid issues, to lose weight. And for me, it is an effort that I make to take care of myself. So we need to actually be able to appreciate and find out what she is able to do. And of course, all patients have hope to recover. So what can we do is to provide patient-centered support. Some strategies very quickly we need to educate our patients on sleep hygiene. We may think that they know, but not everyone is in the know of what behaviors that they need to avoid, behaviors that need to take to make sure that they get better sleep. We need to actually share with them how to do deep breathing exercises in our clinics. It's something simple that we can help them do. You don't need a psychologist to actually be able to do that. Mindful eating, this is super important. It is something that I think many dietitians are now adopting. Mindful eating is about focusing on the food and not talking about how many, what the calorie is. But research has indicated that mindful eating can actually can contribute to the reduction in obesity as well as depression. This is what psychologists do. We help patients to reframe their thoughts. There is a scale called dysfunctional attitudes towards sleep scale. And you will be surprised of how many people actually have cognitive distortions or dysfunctional attitudes and beliefs about sleep that could contribute to their sleeping patterns. And how do we empower healthcare providers? And I'm sure you have heard of motivational interviewing. It is not a fix it all, but it can help us to understand or to support patients to make plans about about the strategies that they can adopt to help them manage their weight better, manage their mood better, manage their food better, etc. All right, and the take-home message is that if we ignore sleep and mood in obesity, we treat the symptoms, not the system. So thank you very much for your attention. I apologize for taking extra
No, not at all, Dr.
minutes. All
Hariyati.
right,
Thank you
okay.
so much. Thank you so
Thank
much. It
you.
was so interesting. I think we should have one session on sleep itself. I mean, I think it's very, very important. But perhaps we do have a lot of questions in the Slido, and I really want to answer all of them. But I'm going to ask the speakers to keep your short. But I would just like to touch upon Dr. Hariyati's presentation first, Dr. Izwan, if you don't mind. I just want to ask Dr. Hariyati, in terms of the food equals happiness. That is what I struggle with. Some patients were given this very potent GLP-1 receptor, GLP-1 GIP combination. The first thing that they do is they lose the appetite, and that kind of makes them miserable. So
Yes.
how do you address that? Food
Dr.
equals happiness.
Prof. Rohana, food equals emotions, mood. It ranges from happiness to sadness. The range of mood, the range of emotions that we experience are often associated with food. And I think this is where our idea of all or none thinking has to actually be erased. You either eat or don't eat. You either eat healthily or don't eat healthily. So one of the things that I find working when I work with my colleagues in IMU, for instance, is to highlight the importance of mindful eating, being able to taste, being able to savor, being able to actually appreciate the food that's being taken, and making decisions about what to have. Kan? I think because sometimes when we say, oh, tak boleh makan ni, tak boleh makan ni, tak boleh makan ni, it is actually very very depressing that you are. And it's a cultural thing, it's an emotional thing, but I think it's very important for us not to actually equate food with something bad, because there's a lot of healthy foods and enjoyable food out there. But I think we have to teach our patients, and myself as well, on how to enjoy the food without gobbling down. So people who are depressed or stressed are more likely to gobble down the food, but people who are healthy and happy are more likely to savor their food, to actually eat mindfully, eat slowly. So the patterns of behaviors that are associated with eating, I think, is also important. Yeah.
Right. Okay. So in relation to that as well, so when you mentioned when you have sleep deprived, and then you actually go for the carbohydrate, which is proven actually, and there's an explanation behind it. But as well as that, the sleep deprivation is one thing. When I wouldn't say it's this generation, it's everyone as a whole, right? So for someone who says I need some time to look at my social media because that gives me pleasure. So I only have time, very little time in the night to get my rest, but I would rather compromise on my sleep duration because I need that 1 hour or 2 hours of social media. How do you address that?
Prof.
Because
Rohana, this is what
social
I
media
do.
is
Yeah,
sensation.
this is what I do with my students now, the Gen Z, they talk about, Madam, I cannot not live with. So I actually do introduce motivation interviewing techniques with them. We want to make sure that we elicit what is very important to them. And they will think that they think that social media is important to them, but they realize how much the sleep deprivation affects their quality of life on a daily basis. Sometimes these questions need to be asked before anyone can contemplate and really be able to weigh the pros and cons of doing things. So it is a hedonistic society. We are the momokkan dengan this need to actually have 10,000 likes for our post at 10 o'clock at night. So they wake up and, sometimes when I ask them, when you wake up, do you really read or do you just find out, kenapa orang ni tak like my post? Kenapa orang ni punya post ramai suka? So it's actually what we call ruminating thoughts or catastrophic thought patterns. So even when they go to social media, it's mostly about the thoughts that accompany this behavior. And we need to actually have, I know we don't have many clinical psychologists or health psychologists out there, but we do need psychologists to be part of the obesity team who are trained to actually help the patients. So hopefully by the end of this year, we're going to be able to offer masters in health psychology and be able to fill that gap. So it's easier said than done, But you're right.
Yeah.
So this
Okay.
FOMO, YOLO, whatever it is, the new things that are they're affecting the younger generation, has a lot to do with perceptions and representation of what they think is important to them.
Right. Okay. And I really like that you pointed out is hedonic society that we have. We really need immediate gratification at any point. But anyway, so we're going to go to the questions in the Slido. I just want to very quickly address. I'm very glad that someone actually noticed that there was supposed to be a question at the end of that statement. Is obesity is a risk factor question mark? So I'm actually glad that someone paid attention after all this years that we've been saying that this is not a risk factor. It is a disease by itself. Oh, I congratulate myself. Anyway, but what we do want to say is that it is a disease which occurs at the very early part of the spectrum, and at the lower end of the spectrum are all these other conditions that we talk about, including OSA, including mental health issues, major depression, etc., etc. So anyway, thank you very much for highlighting that. So moving on to you, Dr. Izwan, Prof. Izwan. So next question, patient with obesity and coexisting OSA, do they need to be on CPAP prior to bariatric surgery? Is the decision affected by severity of OSA? Over to you.
Yes, they do. Now I'm regretting not showing my backup slide because I think when we talk about CPAP and breaking down the vicious cycle, you do need to give immediate effect or immediate reversal of what's happening in patient with OSA. So by having a CPAP, it will open up the airways, it will reduce your hypoxemia, reduce the problem associated with sleep fragmentation and so on. It will almost give an immediate response to patients who have all this poor sleep pattern and so on. But at the same time, you also need to focus on what's causing the problem in the first place. So that's why in our CPG, we focus on issue associated with obesity, for example, exercise and so on. Because if you just using the CPAP, it just open up your airways during sleep. But when you stop using it, it will come back again and affect you again. But if you do that together with reducing your weight, for example, continue doing exercise, you can have more added effect. And in fact, when we have the option of adding in medication, it will give a more beneficial effect in terms of weight reduction, reducing the AHI, and so on. So yes, prior to bariatric surgery, you do need to have that. And in fact, immediately post bariatric surgery, you still need to have the CPAP on board because the surgery does not automatically cure the condition. So you still have the residual sleep apnea. So you do need to have that CPAP. But hopefully after the surgery, your pressure requirement will reduce and it'll be more comfortable for you to use the CPAP.
Right. So in relation to that, next question, do you routinely prescribe pharmacodrugs to reduce obesity in OSA patients? Kayuan asks.
Not routinely. I've prescribed a few. I know in Hasa I cannot do it because I have to go through endocrine team, but in other practice, I can prescribe it as I wish.
Right. Okay. So, but do you routinely though? Because as you know, these drugs are expensive and CPAP also is expensive. If a patient tells you, I can only have one prior to bariatric surgery,
If
which
you can
one
only have
would
one, I would go
you?
for CPAP because that, as mentioned, the effect from that is instantaneous. Patient always mentioned to me, it's like waking up from the dead because they feel the immediate effect following the use of CPAP, so long as they can tolerate the machine.
Okay. Sorry, who says that? Waking up with it? The wife or the husband?
The patient would say that because I mean they've been feeling very tired, feeling sleepy, and so on. And once you give the CPAP, immediately the following day they feel better. Of course, the wife will say, "I can sleep more soundly because there's no more snoring."
Yeah, exactly. I think the partner will be as well, or else it'll be a walking zombie, right? But it would be interesting also, but you said that the CPAP is not treating the underlying cause, whereas the pharmacotherapy is. So it's interesting to hear that you would advocate CPAP first. But anyway, so next question. So very quickly, Prof. Izwan, can you share how to interpret polysomnography in a simplified way and action plan for various results?
Polysomnography, basically they look at quite a number of things that number one is to look at your breathing pattern. So whether you have the cessation of breathing, which is what we call apnea, or you have partial cessation, which is hypopnea. We would look at those figures, looking at, basically your sleep study will measure your chest movement, your cessation of the airflow through your nose and so on. At the same time, we also measure or look at which stage of the sleep you are, because when you have a sleep apnea, you tend not to go into deep sleep. And that's the reason why you're not having a resting sleep. So those are the things that we looked at, and we would measure how bad is the obstruction, how frequent is the obstruction occur within 1 hour. And we'll at the same time also measure the oxygen saturation. So when this happens, we want to look at what is the lowest oxygen you get into. I've just seen a patient in my clinic this morning with AHI of more than 100 and oxygen saturation about 58%. And I always give that example, and when asking them to hold their breath, they will not get their saturation below 95%. But when they're asleep, the oxygen drop all the way up, all the way to 50%.
Yeah,
So
yeah.
that's
So
the simplest way to look at the polysomnogram. Look at is oxygen saturation, look at how frequent they're having the obstructive event.
right, yeah. Sometimes we say like it's incompatible with life. So on that matter, Dr. Hariyati, can I just ask you how you mentioned about the REM sleep? Very quickly. How important is the duration of this REM sleep? We refer to that, right? REM sleep, deep
Yeah.
sleep. That's what most of our watchers are able to monitor now versus the core sleep or the light sleep.
I'm not going to be able to answer that question, Prof. Rohana, because I have not done much research on that.
Right.
But what is the what are your thoughts though? I mean, I would
But
actually not many patients, not many of us actually do get any forms of REM sleep in the first place. They would go back to the first, to the first stage can. But yeah, I would not be able
right.
to answer that question when it comes to mood and obesity. I'll have to look at it a little bit more.
No, my apologies. You were
It's okay.
alluding to the fact that you have to have a good quality sleep.
Yeah, yes.
Yeah. So we're probably discussing about the same thing, that they need to be in a good
They need to
deep
be,
sleep,
yeah, because
and
in
yeah,
the stage 3 sleep and stage 4 sleep, that's where the brain processes all the information, removes all the caches, right? So
yes, that's
usually,
right.
about 4 hours, 3 hours of sleep would be actually 3 to 4 hours of sleep. For some people, I think it depends on the age. I think the elderly do not need as long as sleep as some of
Yeah,
us. Yeah, but
yeah,
ideally 6 to 8 hours of sleep. But the REM sleep should actually make up more than 80% of that, I would think.
yeah. Yeah, so I think this is one of the things that we don't emphasize among our children, our young adults, because they really need this good quality sleep to be able to
Absolutely, yeah.
recover their cognitive function, as you said, or else
Absolutely.
you wake up in the
Yeah.
morning, you're like a zombie, like walking
I think a
around.
lot of people think when they sleep, it's about just physical rest, but they do not know that the brain actually has a lot to do during the REM sleep, that stage 3 and stage 4 sleep. So I think that's something that's part of the psychoeducation that we need to provide to people, that allow enough sleep for the brain to do its stuff, to manage the emotions, to actually be able to process the emotions, and the thought processes that you've had during the day. And one of the things we also encourage our patients to do is to do gratitude journaling. That can help as well. That can aid with the the brain's function to remove all the issues that happen in a person's life during the
Right,
day.
right,
Yeah,
right.
gratitude
Yeah,
journaling has been found to actually be very effective in helping during the stage 3 and stage 4 sleep for that to
right,
happen.
right, right. Thus, I say that we need another separate webinar for that.
Yes.
But anyway, so next question. I would like to answer that is one. I have been diagnosed with OSA. Now BP is difficult to be controlled. And if you are being treated by a respirologist, you need to see an endocrinologist. But you need to have your diet and lifestyle in place first and need to have all your psychological issues addressed. And then we'll see whether you are suitable to be on any form of pharmacotherapy. GIP, GLP-1 combination now is a very effective option and very potent, and it's a very good drug for you to start. However, this should be done under proper supervision by the endocrinologist. All right. So next question, Prof.
100%
Iswan.
agreed. 100% agreed.
Yeah.
To add to it, sometimes we do look at the pressure of the CPAP. Most of the problem nowadays because CPAP that we use are automated CPAP, and they left the pressure at the factory setting, which is 4 to 20, and that's a very wide range. And what happens is when we are asleep, we tend to move about, and there's a difference in posture and so on. So if you suddenly change posture, the obstruction become more severe. The CPAP it will just give you a higher pressure of air, and that sometimes can woken up the patient. So that's why you need to be under proper follow-up so that we can narrow that pressure range and make it more tolerable to you.
Okay, so we have 1 more minute, Prof. Iswan, to answer 3 more questions. If a patient is thin but choking while sleeping in lying position, no choking on lateral position, can it also be OSA? Yes or no?
Yes,
Yes.
that has to go with their anatomical bone structure. So that's why we do have maxillofacial teams on board. And there were quite a number of lean patient in Asian population. So we need to look at their nose structure. We need to look at their upper airway structure. We need to look at their maxillary and mandibular bone structure as well.
Right, okay. All right. So I think unfortunately our time has come to an end to this webinar. We appreciate your questions. We hope this has been very useful to all of you. Prof. Iswan will attempt to answer those questions in his own time. And I would like to thank Dr. Hariyati and also Prof. Iswan for making time to be with Maya's webinar this afternoon. We thank you from the bottom of our hearts, and we hope that you will continue to be with us in our war against obesity in Malaysia as well as globally. And also, ladies and gentlemen, to all of you who are here today, and we hope this has benefited you in many ways. And we hope to see you again in our next webinars with Mayos and Zulip Pharma. And back to you, Karen.
Okay, thank you, Prof. So thank you to all of our faculty speakers today, Prof. Iswan and Dr. Hariyati, for their insightful sharing, and of course, not to forget our chairperson, Prof. Rohana, for her excellent chairing of the webinar and also asking some of the very good questions. So I hope our participants learn a lot from the experts today. As you can show from the screen right now, there is a feedback survey. So I would like to invite all of you to scan the QR code and fill in the survey to help us know whether do you like it, the session? Should we do more in this in the future? Do you like the topic? Should we cover a little bit deeper? So just scan the survey and let us know. So by then, I close this session. Thank you, everyone, and have a nice weekend.
Thank you very much.
Thank you. Thank you,
Bye-bye.
Prof. Rohana. Thank you, Prof. Iswan. Thank you,
Thank you,
Kayan.
thank you.
Thank you, Angel. Bye.
Bye-bye.